Next, we'll move on to the last topic, which is colon cancer. So colon cancer, the most important risk factors will be decrease of fiber intake and increased amount of fat and carbohydrate intake. So decreased of fiber intake, that is why colon cancer is quite common in Western countries, because in Western countries their food intake itself is usually composed of maida kind of thing. So there it will decrease the movement of the bowel, so decreased fiber intake is there, so that is why Western countries are having more of colon cancers. And increased fiber and fat intake is also common over there. And as such, while discussing ulcerative colitis and Crohn's disease also, I mentioned these are pre-neoplastic conditions. Lots of risk of cancer is associated with ulcerative colitis as compared with the Crohn's disease. Then we saw about the various neoplastic polyps, both adenomatous polyps like tubular villus and villus adenomas, and also sessile serrated lesions. Then familial adenomatous polyposis, 100 plus polyps which are adenomatous polyps basically. Apart from that, we also have another syndrome associated with colon cancer called as HNPCC syndrome, or it's also called as Lynch syndrome. So HNPCC is hereditary non-polyposis colon cancer, colorectal cancer syndrome. So here non-polyposis meaning it is not associated with any polyps. Okay, so it doesn't, these polyps don't directly turn into cancers here. And usually this is because of MMR gene mutations. MMR genes are DNA repair genes, so mismatch repair genes, which are MLH1, MSH2, MSH6, PMS1 and PMS2. So these are important. So these genes are being mutated, so DNA repair is not happening properly, which will in turn lead to genomic instability. This we read it in general path also, right? So here there is going to be increased risk of many cancers, the most common of which will be colon, endometrium and ovary. So remember it as CE and O, CEO. So colon, endometrium and ovarian cancers are most commonly associated with HNPC syndrome. Other than that, we can also have GI cancers, brain cancers and skin cancers as well. And when the MMR deficiency is present, it is going to have a right colonic predilection in younger age group usually. And one important thing about this MMR deficient Lynch syndrome will be, here there will be lots of lymphocyte, tumor infiltrating lymphocytes. So their prognosis is kind of better, because you can give some immunotherapy like PD1 and PDL1 related therapy. So avelumab, trasa, and then pembrolizumab. These kind of drugs can be given because they'll tend to increase the tumor infiltrating lymphocytes to cause the death of the tumor cells. So they'll have a kind of a better prognosis as compared to other cancers. So pathogenesis, I told, two pathways are there. So one is adenoma carcinoma related. The other one is sessile serrated lesions, which can proceed on to cancer. So both of the pathogenesis are going to be different. The mutations which happen in these are going to be different. So the first one will be adenoma carcinoma sequence. Here it is going to result in chromosomal instability. So the order in which these mutations happen are also important. So a normal colon, when they have an APC hit, so APC was the one which was involved in familial adenomatous polyposis also, right? So APC mutation or the beta-catenin mutation is going to be there. That is going to cause the mucosa to be at risk. Then they acquire KRAS mutations. KRAS mutations will in turn cause a adenoma transformation. So the mucosa at risk is going to become an adenoma. Then upon that, if they acquire the P53 mutation or SMAD4 mutations, then it will become an adenocarcinoma. Okay. Sequence of APC, KRAS, P53 and SMAD4 is important in the adenocarcinoma sequence. Then we have the sessile serrated adenoma lesions, in which a normal colon, after acquiring a MMR defect, like it is a microsatellite instability pathway, right? So mismatch repair genes like MLH1, MSH2. So these are going to be involved. So that will produce this sessile serrated adenoma, and this sessile serrated adenoma then can acquire BRAF mutations and proceed on to become a adenocarcinoma. So these are again important. So clinically, if you see, the presentation of right colonic cancers and left colonic cancers are slightly different, because in right colonic cancers, they usually present as a polypoidal growth and like an exophatic growth, and they can ulcerate, they can cause hemorrhage. So the patient will present with bleeding PR. While in a left-sided colon cancer, it is usually cause a constrictive kind of lesion rather than a polypoid lesion. It will cause the constrictive kind of a lesion. So it was going to produce a napkin ring lesion, producing the obstruction. Okay. On barium studies also, if you see, there will be apple core appearance. So this kind of a lesion will be there on barium study. It is apple core appearance is seen in colon cancer. So we had seen about colon cancer also. So the final miscellaneous topic in GI pathology will be Menetrius disease. So I was mentioning it in GI cancer, right? It was a preneoplastic condition. It is actually a hypertrophic gastropathy. There is lots of some proliferations, not proliferation, hypertrophy is going to happen. So the rugae are going to be hypertrophied, and it is going to be because of increased TGF alpha. So increased TGF alpha is going to cause this enlarged gastric rugae. So in this image also, if you see, the rugae are quite prominent, right? So it is appearing like a brain. So these kind of cerebriform rugae are seen in Menetrier's disease. So it is common in the body and fundus of the stomach. And on microscopy, if you see, it is going to have corkscrew kind of glands, along with these glands are going to be lined by hyperplastic mucus cells. Okay, so already mentioned, it is a preneoplastic condition leading to gastric adenocarcinoma.